Well, thank you very much, President Bismuth, and welcome. I just want to add my welcome to everyone in attendance. I think it's going to be a great symposium again this year, and I think Mal's done an amazing job with the overall program and the sessions. We wanted to, for the first focus session, look at what I think is a pretty timely issue, particularly given the recent findings of the SVS task force on an independent board, and just a sort of more general look at vascular surgery as an independent specialty. Obviously, we've evolved in terms of our practice quite significantly away from general surgery, which has sort of become more sort of laparoscopic as we become more endovascular oriented. So we've assembled what I think is an excellent, outstanding panel of highly informed folks that may represent somewhat the diversity of perspectives. And then to kick off the session, I'd like to introduce Dr. Mal Sheehan, who has tremendous sort of understanding of a lot of these issues, to kind of just outline for us where the fundamentals are, and then we'll have a series of presentations followed by a discussion of all the participants. So thanks so much.
Thanks, Peter. Thanks for putting this together. So these are my disclosures. I've been a VSB director for 8 years, going on 9. APDVS, I've been involved with the Exec Council for 6 years. I've been on the writing committee with the ACGME and the RRC, the Surgery RC, going on my 3rd year. So I've been kind of deep in this for a while. And, in the past, we've tried to hide some of these debates because it got pretty contentious a few decades back, and, we pretend. But, having been so deep in this, and, as you'll see, the board stuff is kind of nerdy and a little bit dull. So any attention that we can get, I'm very appreciative of. So we're not hiding from these debates. We're trying to bring them more focused to all of you. So Peter told me specifically to look at what Natalie had presented at the Eastern Vascular because she had introduced kind of a similar debate there, and he thought did a good job. And I'm like, well, I could learn how to talk about this like a normal person probably. So I went to Natalie, and she was generous enough. So some of these slides are hers, but this was her first slide. And, poor Dr. Veith here, you don't never want your picture next to anything that says extremely old. But it's really not, I mean, maybe to Natalie this is all extremely old, but it's really not all that old. It's not like Hippocrates woke up one day and is like, screw those vascular surgeons, We kind of have evolved from general surgery to do what we do, and it's all happened over the past couple decades. So to set a debate, right, you have to define your terms. So what is a board? What does a board actually do? And it's pretty simple, and some would say dull and boring, but it's, we define and oversee certification. So we certify individuals. So a board will certify a surgeon, an individual doctor. So all exam processes, everything involved with certifying an individual comes from a board. So as the VSB, we certify vascular surgeons, and as part of that, we have to interact with a lot of other these alphabet soup type things, APDVS, Surgery RC, SVS, and I'll get into what each of those does, just so we are defining our terms. So currently, we call this a federated structure. The Vascular Surgery Board is a component board of the American Board of Surgery. So in doing so, the American Board of Surgery used to kind of be general surgery, and then there were all these sub-boards and whatever, but now we're 6 boards, so it's general, vascular, peds, surgical critical care, hand, complex general surgical oncology. And of those, only general surgery and vascular surgery issue primary certificates. So we're the only ones in the American Board of Surgery who can issue a primary board certificate. So the ABMS, so the American Board of Surgery is a member of the ABMS. The ABMS is kind of the federation of all the boards. There's 24 boards. It's old, it's, extremely old, maybe, as Natalie might say. And so we are, so there's a lot of terminology things. We are not a member board as the VSB, so we don't have vote with the ABMS, with all those others, but we are a component board of the ABS, which does have voting privileges. But we are a board. So if we had a board, and again, some of this is going to be repetitive, but it's important to kind of keep saying it, we'd be kind of small. So we'd be the 3rd smallest board if we were granted kind of a freestanding board status. So where did we come from? We came from general surgery, so there were fellowships in like the 60s in the country, but the official process for starting vascular surgery fellowship started in 1980. So a whole bunch of fellowships popped up all over the country in 1980, and then there needed to be a process of certifying the graduates of that program. So we got a subspecialty certificate in 1982. So if you graduated from one of those first fellowships, you got a subspecialty certificate from the ABS. And then in 2005, we got a primary certificate, which means you could certify somebody in vascular surgery who was not previously holding a general surgery board. And we'll get to that in a second. So in this process, how did we come about? Like I said, 2000 was when the fellowship started, so we needed some process within the ABS to issue those certificates and define what it would take to be a vascular surgeon. And that's when the Vascular Surgery Board came into existence in 1998, 2 years before that. So we were called, insultingly possibly, a sub-board of the American Board of Surgery at that point. So in 2002, the American Board of Vascular Surgery, this would be a separate independent freestanding board within the American Board of Medical Specialties, formed, applied, and was rejected by the ABMS to have a freestanding board. 3 years later, they filed an appeal and they lost again. So this was, by all accounts, we were done dirty by general surgery, and it was clearly general surgery was holding us back. So there's no debate. At this time, general surgery was in our way of becoming a truly independent specialty. There's no debate about that at all. Now, somewhat coincidentally, although probably as a matter of appeasement, that's the year we got our primary certificate. So we did not get that freestanding board, but we got a primary certificate in vascular surgery. So there's a lot of back and forth about the ABVS back then and what, the form, but everything was in true intent, that we were a different specialty. We had evolved from general surgery, but general surgery didn't recognize it at that time. Dr. Stanley, who is a leader of the ABVS, kept pointing to these types of articles coming out that's saying general surgeons had much, much worse outcomes with vascular patients. And this got actual national notoriety. This was in the Wall Street Journal about general surgeons having very poor outcomes with open aneurysms. But another thing happened. General surgery abdicated vascular surgery around this time. They were doing less and less vascular cases. So I've talked to Dr. Veith about this because, I think from his opinion, he lost this battle, but in my opinion, he won. He won clearly because there is no organization within general surgery that holds any claim to vascular surgery at this time, and that was the goal. That was the goal. But I told them, it's like I won an argument with my wife, right? And you go outside and you expect ticker tape parade, USA, USA. But it's not like that sometimes when you win an argument, right? Sometimes it's a slow, painful process and you wish you were just dead anyway. But that's what he feels like. He won, but it's so hard to see that because of how painful and insulting the whole process was. So again, ABMS, 24 boards. How often does a new board form? Not very. The second to last one was in 1979, and the last one was in 1991. So it's not like new boards pop up all the time. So it's a hurdle to get to. So again, some of the other terms you have to know, ACGME. What does the ACGME do? What it does is it certifies training programs. So the board certifies the individual, the ACGME certifies the training programs. So any program director is familiar with these forms which we fill out to start a new program or certify our program or review our program. So there's confusion even among program directors. So every other day or so I get a text, these are the hey Mal texts from other program directors, and they say, so this one I got on the plane right here. My second year fellow is not going to hit his open aortic numbers, can he sit for his boards? So what's the answer? Can he sit? Did not hit the minimum. Yes. That's right, he can, because that's an ACGME number. It's not a board number. The board requires 250 major vascular cases, doesn't specify what type. The ACGME specifies, case minimums in different categories. So the program can get in trouble if this is a trend for the program, but the individuals are not penalized for these things. So again, a lot of confusion on what's what. And what's the APDVS? APDVS is all program directors work together with the VSB and the ACGME on training issues. What's the SVS for? Well, that's really where branding comes in, advocacy, the health of the specialty, or if you want to think about it more clearly, anything that requires a tremendous amount of money is probably coming from the SVS and not from the board, not from the APDVS, and not from the ACGME. So it blends. SVS started this program a few years ago. I was involved with starting new fellowship programs, new residency programs, and we worked with the APDVS, with the ACGME to make sure this could happen. So sometimes it requires everybody. So when you think about what we need as a specialty, more training programs, that's probably going to come from the ACGME. Address burnout, that's probably coming from the SVS. Increase our workforce, well, that's complicated, so multiple institutions will need to be involved. Our public profile, again, that's probably the SVS. And government advocacy, that's the SVS and the ACS. So none of these things are really what a board does. So it gets conflated a lot on what we would gain from having a board. But in order to know that, you have to know how these terms are defined. And so finally, yes, there is a process for becoming a new board of the ABMS. It's complicated. We've been through it once before in the early 2000s, and we could certainly do it again if there was a drive to do it. Cardiology has eyed this very carefully, and cardiology's actually said, you know, we need a board certification in PAD, scarily enough. And last year, they actually applied. Now, it was mentioned a PAD, it wasn't specifically for it, but they applied to be an independent board within the ABMS, and they were rejected. Now, we don't exactly know why they were rejected, but we do know that they were rejected. So these are just things to keep in mind when we kind of debate these terms. If you want more information, I wrote several thousand words about it, so you're happy to look that up, particularly about cardiology's application and why I think I thought at the time they'd be rejected, and I was right, they did get rejected. But the process is convoluted, but I'm very anxious to hear what everybody has to say here today. Thank you.
Well, that's great, Mal, and I think that really sets the forum and the tone for the subsequent presentations. I'd just like to then bring up individually some folks that I think can speak to really distinct portions of this discussion. And first would be our past president, Dr. Alan Dietzick. He's going to present for us value and benefit of an independent board of vascular surgery. Dr. Dietzick.
So, thank you. Mal, thank you for clearing that up about the acronyms. Now I know what they mean. This might be a little repetitive, so forgive me. These are my disclosures. I also want to congratulate John Bismuth on his presidency. It's so well deserved. So, as you just heard, the debate about an independent board first began after Frank Veith's presidential address to the SVS at their 50th annual meeting. And the highlights of his talk were that we needed to separate ourselves from general surgery, that there was growing competition from interventionalists with endovascular skills that were not well trained in the knowledge regarding vascular disease, and that vascular surgery must evolve to survive, and we needed an independent board. And later that year, the American Board of Vascular Surgery was incorporated with the sole purpose of becoming a member of the ABMS as an independent board. So they applied and were rejected, as you heard. Why it failed? Well, as Dr. Sheehan said, the American Board of Surgery was dead set against us separating from general surgery, as you see here in this comment from Walter P. Ritchie, who was the executive director of the ABS at that time. And also there was infighting from the SVS leadership, failure to show a unified front despite the fact that 91% of its members voted in favor of pursuing an ABMS independent board. I gave my SCVS presidential address in 2018 about the anonymity of our specialty and suggested that we should pursue this again. And in 2019, the ABVS was reincorporated, and the mission remained the same. So the debate continues. And as you heard, the function of a VSB is to certify and recertify vascular surgeons, make sure they are well trained and safe. And to this point in time, the VSB has done an outstanding job. The limitations are that all processes, all changes to the certification and recertification of vascular surgeons must be approved or in conjunction with the American Board of Surgery. And there have been no issues today, but who can predict tomorrow? Who could have predicted the changes in our government six months ago? Just ask a federal worker. So the benefit of an independent board is that it would give us flexibility to change the processes for certification and recertification without having to ask another board. We could work directly with the American Board of Medical Specialties to trial any changes we might wish to make. A desire for an independent board is not a vote against the current VSB. It is a vote to change where the VSB sits. That is with the ABMS as an independent board or a freestanding board versus the ABS as a federated one. Now, we would have a permanent seat as a member of the ABMS on the AMA RUC, and this committee reviews medical services to determine if they're fairly valued, and I'm sure you would all agree that vascular surgery has been very unfairly valued. It sets the payment for CPT codes, and then CMS accepts, rejects, or modifies those recommendations. But this is a critical seat for us to have as a specialty. All 24 ABMS boards have their own RRC, and this would allow us to subspecialize and innovate new programs. It would attract more medical students and trainees, and possibly enlarge the number of diplomates that we would have. And I think this is critically important given that our competition in IR and cardiology are training many more diplomates each year than we are. Now, the ACGME claims it does not have the finances to start another RRC. However, I honestly believe that if we became an ABMS board, there would be an intense amount of pressure to make this happen for the first new board in a very long time. The intangible benefits may be as important or more important than the tangible ones. The ABMS symbolizes more than an organization that hands out certificates. It has become its own distinct brand. It symbolizes to the American public and medicine excellence in the practice of medicine. It recognizes and validates that vascular surgeons are experts in all aspects of vascular disease management. There is increased visibility as a result of our specialty, given that the ABMS is its own brand, and we would be the first new board in more than 35 years. It would probably enhance all of our marketing and branding efforts, and certainly most, if not all, vascular surgeons would feel a deep sense of pride, and this would be of immeasurable value. In fact, it has been shown that pride in one's job indirectly influences public perception, and as Lee Atwater, the political strategist of the 1980s, said, perception is reality. So you just heard about the status of the ABCVM application. It was rejected last month. If it had been approved, it would have certified cardiologists as the experts in the diagnosis and treatment of vascular diseases. And certainly this would have resulted in a further shift of vascular patients to cardiologists. It would confuse patients as to who the experts really are, and it would diminish the psyche of most, if not all, vascular surgeons. And this is, I think, more of a statement than a question. It would have been an existential threat to vascular surgery. So now that they've been rejected, is the threat gone? They must wait 2 years to reapply. Will they? Well, that question was answered. James Hermiller, president of SCI, and I'll sum it up in the last few words, the fight has not ended, i.e., they will be back. Would we have been better off had we had an independent board for the past 20 or so years? I think the answer is yes. What did 91% of the SVS members know that some of leadership could not grasp? That an invasion by unqualified interventionalists was taking place, and they were snatching our patients, and that the ABMS would best represent our concerns. I put this little thing here about E.F. Hutton. I was talking to Mal about this before, and most of you probably don't know that that was the logo for E.F. Hutton. You have to be over 55 to know that. So, opportunity knocks again. We have a chance to establish a new standard in the ABS in our specialty domain, making it even more difficult for others to apply in this specialty area. As you're going to hear about from Dr. Calagero a little bit later on, the SVS has sent out a poll asking if you would like an independent board. I would encourage you, whether you are in favor of it or not, to please answer that poll. It's time for us to evolve. Let's make this a reality. It's going to be costly, but if we don't make the investment now, we may have nothing to invest in the future. I thank you for your attention.
Thank you very much, Dr. Dietzich, for your excellent summation. I'd like to bring up Dr. Rabi Char, who's going to discuss with us vascular surgery is already virtually independent with the Vascular Surgery Board. Continued support of the American Board of Surgery remains invaluable.
Thank you so much for the introduction. Thank you, Jean and Mal and Peter for this excellent session, very timely indeed. So those are my disclosures. The only thing really I want to stress is that I don't want this to be a debate. I think we all are working towards the same goals for our specialty. So you've heard about some of the history of the VSB, how the VSB was established in 1998, but vascular surgery became a primary specialty of the ABS only in July of 2006. And at that point, certification in general surgery was no longer a prerequisite for certification in vascular surgery. As it stands today, the VSB essentially defines and oversees all the requirements and processes related to vascular surgery certification, all of them. And we have complete independent control over that. You've heard about some of the other organizations do, the surgery RRC, and the RRC essentially develops and enforces training program requirements specific to surgery. We have 3 vascular surgeons on the RRC, and this hasn't really hampered our ability to get things done. In fact, the new program requirements for vascular surgery were recently changed and approved and are out for public comment, and everyone can look at those before they are completely out and approved. You've heard about the ABMS that currently has 24 approved medical specialties and what it does. And although essentially vascular surgery is not an independent specialty in the eyes of the ABMS, for ABMS matters, we speak in the voice of the American Board of Surgery. So as it is today, the VSB has about 4,000 diplomas or so. In comparison, the ABS has about 36,000 diplomas across all specialties. A little over half of the vascular diplomas maintain both vascular and general surgery certification. And by being affiliated with the ABS, vascular surgery really has a larger voice. We speak with the ABS voice in terms of ACGME and ABMS affairs. In addition to that, we clearly take advantages of their resources as to the exam delivery and development, with access to more than 10 support staff and psychometricians for vascular surgery. So where does the VSB fit within the ABS? Specialty boards, including the VSB, are entirely responsible for exam development and delivery, working with our partners in surgical training to establish a standard. Most VSB decisions, if not all, are not subject to ABS Board of Director approval. The only thing that has to be approved is if it entails a large financial situation. The VSB primary focus is on vascular core training standards as well as education and assessment issues. We also have full control as to which directors essentially are elected to the VSB. New members are elected for a 6-year term based upon competencies that are required but also completely controlled and put in place by the VSB. On that note, we have a call currently for new directors, so anyone who might be interested, I would encourage you to apply, and you'll see the details on the VSB website. So what is it that the VSB does? You've heard that the VSB essentially is another specialty board of the ABS on an equal footing to all of those listed in the green box. But the businesses of the VSB is really carried through the executive committee by different committees that include the directors of the VSB. And this includes the Continuous Certification Committee, the QE Committee, the V-Site Committee, the CE Committee, the Education and Research Committee, the EPA Committee, and the Communications Committee. So the responsibilities are to establish criteria for board eligibility and certification within the ABMS requirement. Most of what we do is really to develop the exam and deliver the exam, and this includes the V-Site, the QE, the CE, and the CCA. And we have full control over exam development and delivery. What content goes into the exam, what format, what pictures to include, whether you have a critical fail or not, and we just utilize the ABS resources. So we do have the authority to manage all issues related to certification. In fact, we recently went through a blueprint redesign with the work of Mal Sheehan to modernize essentially what vascular surgery, what the vascular surgery curriculum looks like, and this is completed and should be out publicly in the very near future. We've worked on the EPAs completely separate from the ABS. The vascular surgery EPAs were essentially developed in conjunction with the APDVS and were piloted, and we're hopefully back on track to enrollment this summer. To understand a little more about a lot of the educational offerings that are done through the APDVS and VSB, I would encourage you to attend postgraduate course session at VAM 2025 that will showcase a lot of the work that is done by the VSB and the APDVS. What is it that the VSB does not do? The ABMS, ABS, and VSB have nothing to do with the match, with vascular surgical reimbursement, hospital credentials, politics and turf wars, residency program accreditation, and other aspirational issues. We all want these things. We just have to figure out what's the best mechanism to influence those things. If you look at it by numbers, why is it, I think, critical to have continued support from the ABS? At the end of the day, it comes down to counting. When you look at ABMS votes, the important votes are deferred to the reserved power boards, a board with proportionate representation. And you see on the left-hand side how many members each of those boards can include. And when you look at some of the existential threats that have impacted our specialty to date, and Dr. Dietzik has mentioned some of those, well, one of them is, of course, the American Board of Cardiovascular Medicine application, which was denied. Recent push by the American Venous and Lymphatic Society to have a separate venous and lymphatic subspecialty, and this hasn't gained any traction. But also there was a push by the American Board of Neurosurgery, which is a similarly sized board, to have a focused practice designation in extracranial carotid stenting, and this was denied. So we are speaking essentially in the voice of the ABS, 40,000 members strong or so, as opposed to what an independent board of vascular surgery would look like. In addition to that, the elephant in the room is obviously the finances. There's a cost that would be incurred. ABS continued support is advantageous as it stands now because of how it might impact the cost of the diplomats to have an independent board. Some diplomats may have to maintain dual certification. A little over half of our diplomats do so currently. And of course, there will be the cost and the inconvenience of starting over in terms of exam development. So to conclude, we effectively function as an independent board with an ABMS member board, which is the ABS. We have the premium of being autonomous and influential. It is really about counting, not necessarily about principle. It is not a compromise, but this has evolved as a progressive result engineered by a group of vascular surgeon leaders through the years, and it optimally positions our specialty within the ABMS community. So thank you for your attention. Those are the current members of the VSB, and I look forward to answer any questions you might have at the end of the session.
Thank you for that excellent summary, Rabi, and I think I share the disappointment of the audience that the Vascular Surgery Board will not be controlling global warming, but we carry on. I'd next like to invite up Dr. Keith Calagaro, President-elect of the Society for Vascular Surgery, to present the recently released SVS task force findings regarding a freestanding versus a federated vascular surgery board and independent vascular RRC.
Yeah, thank you, Peter. First, this is an incredibly timely discussion we're having, as you're going to hear in the next few minutes. Full disclosure, I was a member of that original sub-board of vascular surgery that Dr. Sheehan referred to so long ago. And one thing I learned in doing this is that whenever anyone would make an argument one way or the other about this issue during this task force meetings, someone else could bring up a valid counter argument. That's what makes this such a difficult decision and a difficult issue. What I'm going to be presenting, frankly, is a summary of what you've heard already, because it's been very well outlined by the previous speakers. All right, so the way this started was this task force by the SVS. It was actually initiated by Dr. Mills. He appointed Dr. Dalsing to be the chair of the task force with this purpose, just to analyze the pros and cons of a freestanding or independent board. We did not want to use the word independent because that may unfairly give an advantage to that term. Everyone wants to be independent. So that's why we're trying to use the term freestanding. The SVS task force, this is very important, was not charged with making a recommendation one way or the other, but only to summarize the findings. That's a very important point. Now, the composition, there were 12 volunteer SVS members. We sent out a call to all of you and every member of the SVS, but 4 EB members were on it, including Dr. Harris and myself and the other past presidents and current president. And we really strove to be fair and balanced as best we could. We attended meetings every other week, in person or virtually, for the last 9 months. And the task force interviewed representatives of these societies and freestanding surgical boards that you see here to get feedback from them. Now, the role of the SVS, this again is important, and I learned on the job also. The way this is going to work, and it's in the bylaws, the executive board of the SVS will make a decision whether or not to recommend an independent or freestanding board, but to the current vascular surgery board. The SVS does not run or control the current vascular surgery board. It doesn't work that way. The SVS will conduct a survey, and this survey was just sent out beginning a couple of days ago, and that's why this is so timely, and I appreciate that this is going on now. And we actually hired an expert of how to do a survey to help us do the survey so it was fair and balanced. And we included a summary for consideration when you do vote. But again, this is very important. Anyone dozing in the back, the results of the survey will not be the final decision. It's only another guideline that the executive board will use to make their recommendation. So the current Federated Vascular Surgery Board, again, as has been outlined, vascular societies, including the SVS, submit candidates, but the Vascular Surgery Board chooses the candidates and their own executive board. The primary function, as you've heard many times, of the Vascular Surgery Board is to write board questions and certify applicants, but also, and I think this is important, the American Board of Surgery looks to the Vascular Surgery Board to provide input on any issue impacting vascular surgery. And I double-checked with Dr. Brown, and she agreed that this is one of the roles of the Vascular Surgery Board. So it's not quite just writing exam questions. Now, when the task force put our findings together, there were 3 versions. There's a 35-page report. So for those of you who want all the details, you can go there. There's a 3-page summary, but myself and Dr. Harris and others said, you know, everyone's busy. They ain't going to read a 3-page summary. Let's put it on 1 page. And we did that, which was challenging. And that's what I am presenting to you now, is what this 1-page summary is. But please read at least the 1-page summary that is included when you vote, so you can make an educated decision. All right, so we thought when we reviewed all of this, there's 3 categories. There are equivocal findings, and then findings favoring the status quo and others favoring a freestanding board. All right. The bottom line, both models have been successful. The current board is, Vascular Surgery Board is successful, and other independent boards are successful. Branding, we concluded it's somewhat indeterminate if a freestanding board will be more beneficial. This is controversial, but that's what we concluded. We also thought it was indeterminate if growth of vascular surgery will benefit from a freestanding board. And again, this was commented on before, but as I said, you can look at it one of two ways. The RRC, or the ACGME, we met with them, and their representative said they are not in a financial position to grant a separate RRC to anybody. They just don't have the funding. So will a freestanding board help us get an RRC? If you just go by that, the answer is no. On the other hand, this is what we did every time we met. On the other hand, if there is a freestanding vascular board, and every year that freestanding vascular board complains and bitches and moans to the RRC, saying every other freestanding board has an RRC, maybe in 2 or 3 or 5 years, vascular would have its own RRC. But you can look at it both ways. All right. Now, there are factors, or findings rather, that favor the current Federated Vascular Surgery Board. It's working well. No one has ever thought otherwise. They're doing a great job, and it's a lot of work. It's unclear if the current vascular surgery members would participate in a freestanding board. If so, the ease of transition will be much easier. If not, it's going to be much more difficult, and we'll have to get volunteers. But this is the biggest thing, and this is what I think many of you are most interested in. What's it going to cost? Well, the SVS hired a financial expert to do this. We had our own analysis, but then we said, let's get an expert. And the initial outlay, he concluded, would be about $5 million if the board is in place in 2 years, and $10 million if it takes 4 years to get a board in place. What that comes down to is, how do you do it? Well, you can try to get donations, but the SVS, you can get a SVS loan until the new board can sort of pay back the loan through operational income, meaning paying more. What does that mean? Well, that means the costs to diplomats would increase about $200 to $400 a year for diplomats. So you got to say to yourselves, is it worth paying that much more money to have a freestanding board? Now, the findings favoring an independent or freestanding vascular surgery board is vascular surgery definitely fulfills all criteria for a freestanding board. There's no debate. Relationships, we think, will be cordial with the ABS. That's based on feedback from the ABS rep. The ABMS would issue certificates even if we have a freestanding board. A freestanding vascular board would have its own independent vote at an ABMS board, but a lot of people are saying, well, that doesn't mean that much, but probably what does mean a lot is a freestanding vascular surgery board which have its own seat at the AMA RUC. As you've just heard, that might help reimbursements. Again, a little controversial, but it might help. And similar size freestanding boards, colorectal and thoracic surgery, are satisfied with their structure. You've heard this before. The American Board of Cardiovascular Medicine application was not approved, but they can reapply in 2 years. This one factor, we've now moved away from the list that you read in terms of things favoring a freestanding board, because on the one hand, it got turned down. On the other hand, if they reapply in 2 years and if they get it, will all SVS members saying, what the heck are you guys doing? How can cardiovascular have their own board, but vascular surgery does not? Let's get our own board. That ain't gonna happen, frankly, if we go through this and we decide now we're not gonna do it. So again, it's a pro and con depending how you wanna look at it. But that factor has dropped away, favoring a freestanding board. It's an equivocal factor, we think. So in summary, this is clearly not an easy decision. Please make an informed decision when you vote. The SVS is just trying to serve our members as best we can. That's why we put a lot of time and effort into it. And regardless of the decision, we all must remain unified if we're going to get anything done. Thank you.
Thank you very much, Dr. Caligaro, for that excellent summation, and I would second your plea for coordinated cooperation between all the members of the vascular community. Our last presentation before we start our discussion is going to be by Dr. David Hahn, establishing an independent vascular RRC, the pathway, value, and limitations, and I think it's quite timely given the RRC discussions that have come up.
Well, thank you, and thank you, Dr. Ferries, Dr. Bismuth, and the rest of the organizing team for inviting me to be here. By and large, everything that I was going to say has been more or less covered, so thank you for that. So maybe I can just try to fill in some of the gaps that might still exist. By way of disclosures, I am a director of the American Board of Surgery, and I was a member of the RRC for 7 years. And then thank you for reminding me of another disclosure. I did just complete a term on the AMA RUC and continue to serve as the vice chair of the Practice Expense Committee. So I do need to disclose that as well, since it seems like that's a point of discussion. So what I'd like to try to cover here, and might be able to move this through a little more quickly, again, given since most of it has been covered, is just to fill in some gaps around the surgery RC. How is one nominated and appointed? Who are the members? And then talk a little bit about the pathway to an independent RC. What are the rules and what has been done previously? And then maybe just talk a little bit about some of the values and limitations. But again, I think a lot of that has already been covered. So the RC for surgery largely parallels what I think was shown relative to the American Board of Surgery and their certification process. So there are two primary specialties that grant their own training certificates. This is all sitting within the surgery RC. So general surgery and the integrated vascular surgery pathway can give their own primary training certificates. And then there's 5 subspecialties which require completion of another training program in order to enter these programs. So complex general surgical oncology, pediatric surgery, both require general surgery residency in order to enter those. Hand surgery can be entered through orthopedics, plastic surgery, or general surgery. Surgical critical care, as many of you know, have many different pathways, including anesthesia, emergency medicine, OBGYN, that can enter that training program. And vascular surgery fellowship currently only allows general surgery, but as somebody alluded to, there are new program requirements that are coming out, and in that is allowing folks completing a thoracic surgery integrated program to then move into a vascular surgery independent program. So those subspecialties all, by definition, require another program, and the primary specialties, again, by definition, can be accomplished without having to go through another training program. So you heard a little bit about this. There are 3 nominating organizations for the Surgery RC. There's the American Board of Surgery, there's the American College of Surgeons, and the AMA. There are other organizations that that put folks onto the RC, the AOA, which came about when we united that training paradigm between osteopathic and allopathic about 8-10 years ago. There is a public member and there is a resident member. Those do not come through nominating organizations. And these nominating organizations typically submit 2 nominees to the RC, and then the RC submits one of those names to the board for final approval. This is about an 18-month process because the nominations have to go in a year in advance, and they have to be approved by the board. Everybody serves a 6-year term except for the resident member, which is a 2-year term. And in the deliberation, there are many things that are taken into account, but one thing just to note is geographic overlap is a very important issue because, again, by rule, if you are in the same state as a program that's under review, you are recused. So if you live in, let's say, Delaware, that's probably not a big deal, but if you live just across the border in Pennsylvania, that becomes a big deal. If you live in southeastern Pennsylvania, you can review a program in Delaware, which may be 5 miles from your home, but you're not allowed to review a program in Pittsburgh, which is 5-6 hours in the other direction. But again, we pay well, not we, because I'm not a member anymore, but there's a lot of attention paid to geographic overlap. This is the current RC membership, and Stephanie Heller is a trauma acute care surgeon at Rochester, Minnesota. You may recognize the name of the vice chair, Sunita Srivastava, and then Rachel and John Rechtenwald. Rachel Nicholson are the other two vascular surgery folks on the RC. And just to give you some line of sight relative to what that's looked like, we have had 3 members of the RC come from vascular surgery, going as far back as these not-to-scale arrows will show you, which is, Ron Dahlman, I took his seat in 16, and Sunita took mine in 23. Joe Mills transitioned over to Rachel Nicholson, John Ricotta to Jim Valentine, and now to John Rechtenwald. And it's worth noting that Sunita is the incoming chair of the RC starting this July. So talking a little bit about the independent RC, what's the path forward? So if you go to the ACGME website, buried all the way down at the bottom is a thing called policies and related materials. You click on that and you get to the manual of policies and procedures. You click there and this is what you get, which is policy 12.2, which is the designation criteria. I'm not going to go through all that because you can certainly look through that on your own if you're interested in the granular details. But I would point out the fact that this describes at a minimum what is required for independence. And so the questions, I guess, that I would try to answer here in the remaining time that I have is, does vascular surgery meet criteria for designation for which accreditation will be offered? And so what happened, as many of you know, is in 2018, the APDVS submitted an application for an independent review committee. SVS conveyed their complete and enthusiastic support. I think the signature on that letter is actually in the room. February 2019, the ACGME Board of Directors said no. A few months later, APDVS said, for compromise, maybe we could consider changing those nominating organizations to SVS, the Vascular Surgery Board, and the Program Directors Society of Vascular Surgery. And the ACGME responded that per their bylaws, which again you can look up on their website, that in order for that to change, all 3 of the nominating organizations have to agree. And so if none of the current nominating organizations, this was in their response, is willing to cede a nominating position, the proposal would advance no further. And so that was the end of that process about 6 years ago. So, I guess the question to answer is, what is the unmet need? And I think you heard this a little bit earlier, is would or should the ACGME incur the expense of an additional RC? So I'm just going to, not to sort of take sides, but just because I've sort of been in the mix with all of this, what I've commonly heard was a concern about the lag time between getting vascular fellowships to be able to be approved in institutions that have no general surgery program and how long it took for that to occur. So I just wanted to give you the timeline of what happened with that. So in June of 2017, the ACGME Board of Directors said, okay, we'll let the individual RCs determine if these subspecialty programs can apply with just an accredited sponsoring institution as opposed to a general surgery program. Later that year, the surgery RC said, yes, we want to do that. And then the following year was when the first application came in from Alina to establish that fellowship program. So it did take a lot of time, but I think that once it was out in front of the surgery RC, it moved through rather expeditiously. And you heard this alluded to as well, the new program requirements, the major revisions are just now coming out. They are out for public comment for about another week, and I would encourage you to go to the ACGME website, look at them, and provide public comment if you're so inclined. The writing committee, you see Chandra R.A. is a surgical oncologist at the University of Nebraska, a member of the RC. Kathy Andelsek is a family practice physician at Duke, who is a member of the board of directors. We included them partly out of mandate, but also partly out of just wonderful line of sight. We had some former RC members. At the time the review or the writing process started, Rachel, Jim, and I were on the RC, but we asked our incoming folks, John and Sunita, to join us as well. And then Candace Wolf, who is a resident and also an osteopathic physician, and then Callie Johnson, who many of you know, who actually just reached out to me and said, can I do this? And I said, sure. She was a young vascular surgeon, provided a lot of input. So for those of you who may be younger in the room, never underestimate the power of just reaching out to some of these kinds of things, because you never know where it'll lead. And Callie ended up being just an incredibly valuable member of the writing committee. Everybody who knows me knows that I always show this slide whenever we talk about the major program revisions. And these are people who were invited to Chicago on behalf of the ACGME to spend time going over the new program requirements. It's a list of many people who are in this room and people who I'm sure you all recognize, and I think it just speaks to the commitment that many people took to develop the new training requirements in vascular surgery. So does vascular surgery meet the criteria for designation of a specialty? Yeah, it probably does. I think if you look through those, you could probably agree with that. But would they incur? I think you already heard this, and maybe it's not a probably not. It's probably a not. But at any rate, that's not our decision to make. That's a decision made by another entity. So I think it really just sort of depends upon your perspective of how you're looking at this, and I just really look forward to the discussion. So thank you very much. I appreciate your time.
Thanks, David, and thanks for that last slide there. It was humorous kickoff for things. Maybe what we can do is just have our moderators briefly introduce themselves and sort of give their disclosures, and then if you guys want to lead our discussion, I think that would be fantastic.
Sure. So Kelly Brown, I'm from the Medical College of Wisconsin in Milwaukee, and I'm the current chair of the VSB.
Linda Harris, Buffalo, New York. I'm the current vice president for the SVS. I also served on the APDVS as president, and I also did a term on the RRC for vascular when we expanded from 2 vascular surgeons to 3 when we asked for it, and they did give it to us.
So my name's Dennis Gable. I'm in Plano, Texas. I am in private practice, so for the diversity part of the meeting, but also currently the chair of quality for the SVS.
Great, and please, I would encourage everyone from the audience, if you have thoughts or questions or topics that you think are worth pursuing. If we could go ahead and turn them.
Can you guys hear me? Yeah. So I have a few sort of sarcastic comments to make because unfortunately there has not been a convincing argument for or against. It seems that one of the major issues I have come up with are, there's a sense of pride and belonging if we have a separate board. I think the solution for that is either counseling or medication because it's a big expense to do this. The issue about branding, I think having a board would not necessarily matter to patients or referring physicians because folks only know, are you board certified or not? They don't know about the intricacies of all these things. The threat of cardiology is they're a big group who is willing to do anything they want to create more cases and so forth. And I think that threat comes from us. Cardiology has taken a lead in PAD. In 2005, they came up with the guidelines with the American Heart Association. We fell behind. The American societies has fallen behind in terms of, compared to the European societies who have been at the forefront of getting guidelines up and about faster than what we do here in the US. And we've had our head almost underground like a, I don't know, ostrich or whatever animal puts their head underground because we've been very happy and candid about, we are part of the Heart and Vascular Institute or a Cardiovascular Institute. All of these carry the heart part. So this is where the cardiologists are taking an advantage of the sort of construct of our specialties. So I think it's going to be super important for us, instead of trying to deal with the board, is trying to address the marketing part, the branding part. We need to make sure that folks understand that we are vascular surgeons and not cardiovascular. Cardio is just the heart. I get so many folks calling my office looking for a cardiology appointment because I'm branded as Cardiovascular Surgery Associates. Folks don't know what Cardiovascular Surgery Associates is. They know vascular surgery versus other things. And I think if we're able to, instead of using the board for branding, we brand ourselves differently. All the societies come together and we work on that branding. That is huge. I had an opportunity to interview for a little online article on DVT, which is interesting because who did they also interview? They interview interventional radiologists who don't treat DVT medically. I mean, they do a procedure, et cetera. And a cardiologist, and the cardiologist was so active about treating DVTs only interventionally, but there was not much of a treatment. So we have to really.
May I ask a question? Sorry.
Yeah, we got to get moving.
Yeah.
Because I know that you're talking about your.
Eric, if you want to talk into the microphone, but
Yeah.
let's just.
Why don't we let him just finish real quick and then we'll go.
So my issue is, I'm not sure if we're going to generate more problems than figuring out a solution to the problems that you guys have posed. And that's my concern.
Well, I mean, are we conflating, I think this has been touched on, but are we conflating, the duties, responsibilities, and implications of an independent board with branding, or are they really tied together? I mean, Alan,
First
you've
of all, so Erica, did you have a question for him?
No.
Okay. So real quick, we are an independent board. Like, the word independent is really a misnomer. So it's a freestanding versus the federated version. So let's just be clear. I mean, we are independent. I can tell you, as the chair of the board currently, we make all of these decisions. We decide these things ourselves. The truth is, because we are part of a group that has a bunch of boards, we can't go out and spend all of the board's money on something that only the vascular surgery board wants to do, right? So that's just that's just the realities of a business. The truth is, if we were a separate board, we also couldn't do whatever the hell we wanted, because there wouldn't necessarily be money for it. So I don't know that would be different, but the word independent is a little bit of a misnomer, so I would just say that. The second thing, I think we are conflating it a little bit. I'm sure Alan disagrees with that, but I believe we are conflating it. The last thing I wanted to say really quickly is, although there are organizations that nominate people to be on the board, it is not an organization representative board. So you can independently apply. You do not need an organization to put your name forward. You can independently, if you want to do it. And we've taken people who have we're not only taking people from a society recommendation. So if you are interested in serving on the board, you certainly can put your name in. And it is a competency-based process to choose. And that was just a little nuance from something that Keith said I wanted to bring out.
And just a quick comment, you're going to hear more about the branding initiatives from the SVS for all of us a little bit later in the presentation, but you're right. We are working on that, and we're working on guidelines. Erica?
So I think what we want to know from you, Alan, is what will this independent board do to prevent everyone else from taking a piece of our pie? What is your goal for that?
Well, I think, you first have to ask, why would the ABCVM get rejected by the ABMS? And I think it's because they don't have the proper training to say that they are the experts in the care of vascular patients. They didn't substantiate that with their application. And I think we can substantiate that with an application, and that would make a big difference. And I do think that when you say conflate, do I think it's the answer to marketing and branding? No. I think it will very much enhance our marketing and branding to be able to say that we are the board on the ABMS, that in this domain of practice, we are the experts. And I think, on the other hand, if the ABCVM gets that position, I'm glad they got turned down. This was going to be a justification for us to become an independent board if they managed to get on the ABMS. To me, that's already too late. Now we have an opportunity. They're going to apply again, there's no doubt. And so I think that if they become that board, they're going to crush us. And they're going to use it to market themselves and brand themselves. So I think it's critical.
I think that they already are crushing us. I don't think having a separate board matters. I think they're crushing us because there's 30,000 of them and there's 3,000 of us. I mean, that's the biggest part of the problem, right? There's just not enough of us.
Well, that is a big part of the problem. And that's why I think we would also be able to make more of us if we were an independent board. That's my opinion.
That would have nothing to do with, an independent board would have nothing to do with making more of us.
Well,
we will add an extra day on exams. We'll let more people sit for the exam.
If we had our own RRC, Kelly, that might make a difference.
That's not going to happen.
And, well, why do you say that's not going to happen?
Because they've said they're not going to do it.
No, they didn't say that.
They've come right out and said we're not going to do that.
Okay, they didn't say that. Were you at the meeting?
Yes, they did.
Because they didn't say, they said they can't do that right now because of finances. So I would ask you, do you think they're going to have 25 boards, 24 are going to have their own RRC, and what are they going to do with the 25th board?
So
I
basically,
think they think it's working well now. They would just leave it the same.
the ACGME
Oh, they're going to make
gets-
us combine with another
I
board.
think
Well,
so.
the ACGME gets funds from institutions, and they get one set of money, irregardless of how many programs there are, and that gets divided amongst all the boards. And because they have not changed that number That's why they're saying they're not going to expand. Now, I don't know if they'll ever change that number, but it was a financial reason that they did say no.
Yeah, so I was going to say, as you can tell, even from the task force, we had some disagreement, some agreement, but I came into it not having one way or the other, but I side with Alan on this in that how many people think that the cardiology board or the American Board of Cardiovascular Medicine is not going to reapply in 2 years? If you think they're not going to reapply, then I think you should reevaluate because they're going to reapply. They are well supported. They have 30,000 plus people against it. The problem is eventually they're going to get to the point with the support they have that they will get a board put through. Once that happens, and this is what I'm saying, I agree with Alan, once that happens, then the horse is already out of the barn of who the vascular leader is, because in their board application, if you read the whole application, less than 5% of the questions on their board approval test or exam was set to deal with vascular surgery. But yet, every single person that finished a cardiac fellowship was going to be board certified. So that means the EP physicians, the interventional cardiologists, cardiology, once they go through all that, they're all board certified. So rather than being reactive, we have a much better chance to help with the branding. It's not the answer. I fully agree with that. It's not the answer. But to help with the branding and to help us understand, or help the people understand and patients understand that we are the board certified, we are the leader in vascular care. And that's really what the goal is from a quality standpoint.
I think there's another question.
Yeah, I was going to say, why don't we open up?
So I think our politicians have started to learn that what people care about most is the money in their pockets as voters. And so the most compelling argument that I've heard here is the independent seat at the RUC that might lead to better reimbursement for us. So I'm wondering if maybe Dr. Hahn or maybe Dr. Roddy could explain to us that process now and how it would change. I mean, right now we have codes for fenestrated EVAR, but there's no RVUs assigned. We don't even have codes for branched EVAR. You know, is this really going to make us more money, and if so, how?
So that's a great question. Just to address one little nugget of what you brought up, which is that there's no value associated with EVAR. Understand that when those codes came before the RUC, we were unable to get adequate survey data from the membership to provide any line of sight to value them appropriately. So we're very sensitive to that. We're very careful about bringing codes before the RUC that have not developed significant or enough penetrance into daily clinical practice to allow proper valuation. So I just want to make sure you understand that was not so much due to surgical or vascular surgical representation on the RUC. That was a process issue that another seat on the RUC would not solve. You know, I think that there are lots of pieces to that, and so I'm going to do my best to deftly dodge and weave that question. But it's fair to say that cardiology already has a seat on the RUC. So, you know, the sense that if cardiology gets a board, now they're going to get a RUC seat. So if we get a vascular surgery board, we'll get a RUC seat. You know, the parallel's not there relative to some of the board and RC discussion that I've heard going around. You know, would having another seat be valuable? Absolutely. Is it going to make a difference? Hard to tell. You know, there's already a bit of, as I'm sure everybody is aware, this push-pull between procedural specialties and what some people call cognitive and others call non-procedural specialties. Would adding another seat in that balance be favorable? Yes. Would there be a response that there might now be another seat for a non-procedural specialty? Probably. So I think that it's certainly a worthwhile piece to investigate, but there's a lot of nebulousness around that. And then, you know, I think there was a comment that vascular surgery has not been favorably valued at the RUC and subsequently with CMS decisions around payment. I would suggest that we have been as affected as other specialties, and you know, without trying to be too biased around it, I think we've actually done a lot better than many people would have predicted that we would have done relative to some of the decreases in RVU valuation that have occurred in many other specialties. And then I guess one final point is relative to that. we do a lot of work with the American College of Surgeons on the coding and reimbursement side, and I would tell you that aligning ourselves with a much larger organization in terms of lobbying for things like ensuring that the E&M visits built into the 90-day global are, because many of you may know that those payments got not reduced but stayed level when the outpatient E&M visits went up. That the college argues on our behalf for that as well because they're interested in it as well. So there's a lot of power in being part of a larger group with a bigger voice.
Hi, Ash Mansour from Grand Rapids. Very great discussion from everybody. Like many of you, I treat patients with arterial disease and venous disease, and I see a lot of patients who've been treated elsewhere. And my question to all of you is, will an independent board prevent cardiologists, dermatologists, internists from treating veins, all sorts of specialties that are treating patients with veins, doing procedures in their offices, cardiologists who have OBL. As you know, Grand Rapids been a focus of an article in the New York Times where these cardiologists were doing atherectomies on patients left and right. Some patients were getting 10, 12, 15 procedures in a year's time because they were told by the cardiologist that they couldn't walk.
Yeah.
Is an independent board going to change that?
So no, a separate board, the vascular surgery board, whether it's separate or in the federated model, doesn't have anything to do with credentialing.
That's all local. That's all local politics. And as you know, there are many things that cross over into multiple different specialties. As you mentioned with ours, carotid endarterectomy can be us, neurosurgery, general surgery. You look at colonoscopies. How many different specialties do that? So having a federated or having a freestanding board makes no difference, unfortunately. That's all local.
But what does make a difference there is if cardiology and the American Board of Cardiovascular Medicine gets a board certification, they will go, guarantee it, they're going to go and say, we're board certified, we're going to be able to do EVAR, we're going to be able to do a fenestrated graft, we're going to be able to do these because we've had training and we are board certified. That is my personal opinion.
Well, when you get credentialed, you have to show a case log, right? And so you have to actually have been doing the cases in order to get credentialed in the cases.
Yeah, they're doing that already.
Yeah, so
So Dennis, I understand your point, and I understand what you're saying, but I don't think the credentialing is the credentialing, and it's different at every hospital. But the bottom line is you have to show your case log. So it's not like they can just come out of a fellowship where they never did any of these and then start doing them.
So what we can do though, because credentialing is all local, but what the boards do is provide certification. So what's very important is how your specialty is defined. So I would ask all of you to go to the American Board of Surgery website, find the VSB, and see how our specialty is defined. And I think you'll be very happy with that definition. Go to the ACGME, find vascular surgery, see how we've defined that specialty. And I think you'll be very happy. So it's going to be very difficult for other specialties to claim that these things are within their realm. And going forward, when neurosurgery tried to have a focused practice certificate in extracranial carotid stenting, they were ultimately unsuccessful because that is clearly within our domain. So these are the types of nerd out things that we fight over that may not be so exciting, but these are critically important when we get down into the weeds. And so as reimbursement becomes hinged on this, which is our hope, right? I mean, we can't come out and say, hey, follow what the board says, but that's the hope, is that more and more people pay attention to these board definitions as certification, as reimbursement is linked to it. So the first thing is to look at our definitions, because the way we have defined vascular surgery would have been unthinkable in 1999, in 2000, and 2001, because we clearly own arterial, venous, and even lymphatic outside of the skull and pericardium. And there's no way that that didn't happen without all of this, all the people who contributed to this fight. So while it seems unimportant, it actually kind of is.
Murray?
Hey, thank you. So two things. I had the privilege of being assigned by the SVS to work with the American Heart Association and their board about their practice guidelines. And actually, I would say that there's not all cardiologists are created equal. There are a whole bunch of people within cardiology who would like subspecialty training and certification within their own scope of practice, right? Not every cardiology fellowship does peripheral work. Our guys don't, but we can't stop them going and starting a heart and vascular institute in the community, right? So I do think that there are cardiologists that would like their own subspecialties within their specialties, like structural, like EP, protected. So I think not all cardiologists. So I think that is really important, actually, in an independent board for them to be able to delegate who does what within their own scope of practice. And I do think they want that. And then the second one is a little more political, but do we really want the SVS membership voting on something that they really probably don't spend a lot of time thinking about other than the branding side? I mean, how many SVS members really understand what the board does? I just did the survey. I don't think it's a good idea.
I mean, obviously, that's a question, but what we didn't want is to have this behind closed doors. We're trying to reach out. We want education. That's why this has been presented at multiple meetings. I hope all of you take the survey, but if you're going to do the survey, please read the information, because uneducated vote is worthless, completely worthless.
Well, I think we also need to put out a lot more information about it so an educated decision can be made. And I think it's important that there is a survey, that the members be polled and they have an input into this. Clearly, it's their responsibility to learn about it, but it's critically important. It was important then, and it's as important now. And I do think that if we're a member board of the ABMS, when we call out another specialty, it rings truer and louder than when we're not a member board. I just like saying the Statue of Liberty doesn't symbolize something more than just being a piece of art sitting in a bay. It symbolizes more than that.
I just want to caution with that statement really quick, because a voice of 6,000 members is different than a voice of 36,000 members. And yes, the cardiac application is going to come back in 2 years, but what is more likely to block it? Yes, they're going to change things, but is an isolated vascular voice of 3,000-4,000 members going to be as effective as the ABS voice? Because the ABS response was exactly the same as the VSB response in terms of rejecting that application. So we may be shooting ourselves in the foot if that materializes again. So we just have to be careful, because we all want the same thing. What's the more secure way to achieve it?
So we have a couple questions back here.
Thanks, Jonathan Cardalla from Yale. A lot of this is new to me because I was in practice in our 51st state for the first part of my career when you guys were working this through. But Rabi, your comment is a great one, that it seems that the offense on this is defense, and the defense is the number of votes you have, and it's the very defense of the ABMS that crushed the cardiovascular board, if I understand it.
Well, we don't quite know, because the details are never going to be divulged, but there are many factors that went into this that we're not going to know, and whether they're fixable or not, I can't answer that. I don't think anyone can.
Can I ask Alan or Dr. Gable, where would we be today had the independence been garnered back when Dr. Veith called for it, and maybe someone on the other side, present where they think we would be had we been independent back when it was initially proposed?
I think I tried to allude to that in my presentation. I think we would have been better off. I think we would have,
How?
well, I think we would have been able to call out a little bit better and a little bit louder with more people listening as an ABMS specialty board, the kind of nonsense that's going on in cardiology. I don't think we could have stopped. Listen, there are some well-trained cardiologists. Unfortunately, there are a lot of very, very poorly trained cardiologists doing this for the wrong reasons with very little knowledge. And I think maybe we could have changed the curve.
But if that's the single existential threat, it seems to me that the defense to that threat is numbers, and an independent board, and again, I'm still learning this, wouldn't have the numbers, right?
So as an ABS board member, every board gets one vote except for certain items that I think you alluded to, right, Robbie?
Yeah.
But when it comes to this, I think they have an equal vote. So that's a very powerful thing.
But if the credentialing is local and someone goes to their hospital and says, I've done 5,000 whatever angioplasties, they're going to grant them credentials regardless of what an independent board thinks of their training and experience. Am I correct in that or no?
It just depends on locally what the requirements are for that facility.
I would just say one thing. The person who sits on the ABMS for the American College of Surgeons is the executive director, which right now is Joe Beiske. And that person has a fiduciary responsibilities to all of the members of the American Board of Surgery, so all of the component boards. And so anything that comes up, any of these focused practice designations, any of these questions that have come up, at least as my tenure the chair, Joe and I chat about it and talk about the role that the ABS should play and the way the response should read, and the response from the ABS has to defend us because we're a component board. Splitting, and this is just like trying to answer the question, how would we be better? Like it's hard to tell, right? It's like in surgery, when you make one decision, well, that decision's made. You don't know what the other decision would have resulted in. But what I can tell you is that if we're not a member of the ABS, there is no fiduciary responsibility. And so then that person can vote the way that their board members or the people within their constituency think is the right way. So who's to say? I mean, I don't know how that would go going forward, and some of that depends on the issue brought forward, and a lot of that would depend. So in the specific example of the cardiovascular board, it would depend on how that repeat application read and what the issues were.
I just want to briefly address that. That's the threat that's been used. If we're not a part of them, then we're against them. The fact is that having a full vote on the ABMS board, it would not serve the ABS well to disenfranchise us. It just wouldn't make sense for them to do that. And in fact, they would probably...
It might, though.
Well,
I mean, right
me?
now they're held to defending us. I'm not saying that they would do it out of spite. I'm not saying that they would do it because they don't like us. I'm simply saying, depending on the question brought forth, they vote for their constituents.
But the feeling
right now, we're one of their constituents.
The feeling
One of their
So there's no way that
We're not the only
there's no way that the executive director could go to the ABMS and say, yes, we support this cardiovascular board, as long as vascular surgery was.
I just want a point of information here. When the cardiovascular board applied, ABTS voted for it, and ABS voted against it, just for everybody's knowledge.
Sir.
Yes, thanks. Vince Rowe from Los Angeles. I just had one quick question and comment. The question's really to Dr. Harris and Calagaro. So if we're all doing the survey, but the executive board has the final decision as to what we'll do, how valid is that survey based on the results from the voice of the whole society? And would it be a little bit better if we extended some of the decision makers for the results of the survey, maybe to the leadership of the APDVS, leadership of the RRC, where we have vascular surgeons, or the leadership also of the VSB, to get more stakeholders in making this critical decision? And my only comment would be that even though we're a smaller organization, our voice will matter, and our voice, I believe, will reverberate better if we're not muffled.
So we are trying to look at getting information from multiple sources. We will look at who responds, how many people respond, what level. So if we have, and I hope this won't happen, only the people who are retired vote and no one else votes, that would likely have less impact on us than having a broad spectrum. If we only have 100 people vote, we're not going to put as much weight on that because that's clearly not necessarily showing what the whole group says. And as a matter of fact, it would show that it really doesn't matter to most people if only 100 people vote. So we want to have a lot of individuals contributing information. We are trying to gather all the data. The point is, if we're not unified, we risk what happened 20-some years ago where we almost had a massive split in our organization. We're trying to come to the right answer for all of us. We're all human. We're all going to make mistakes. We're trying to make the decision that everyone can come to the most, and that's the way we're going to have to go forward. And we really need to come together in a unified fashion, one way or the other. Keith? Keith, did you have something to add or no?
Yeah, Vince, I get your point about maybe the SVS approaching the program directors and the other societies you mentioned and getting their feedback, I think, is what you were getting at, and trying to put together a compilation of sort of opinions and come up with one recommendation. You know, it's not a bad idea, but this task force worked on this for 9 months, and I think this is a great discussion. But I could say every comment I've heard, there is a counter argument. And to now push off the decision by the SVS Executive Board and try to incorporate everyone else's opinion, I just don't know if that's feasible. I get your point, but the last comment I want to make is this was not even an easy decision. There was a lot of debate among the task force. Should the results of the survey be the determining factor? I think he was first. We talked about this for hours. It wasn't a 5-minute discussion. But we concluded, and the bylaws say this kind of a decision comes down to the SVS Executive Board. Not, I know it sounds crazy, but not necessarily a vote of the members. But just think of it this way. If the result of the survey comes out that 51% of our members who vote are against a board, should we say, okay, that's the results of the survey, we're not going to go with a board? On the other hand, let's say 80% are against a board. Well, that's something the executive board will take into consideration. So we wanted to reach out to you and to SVS members to get your opinion and hopefully make an educated guess. But you're right, it's very difficult to just read a one-page summary and come up with a decision, but the task force did the best we could.
So we're short on time here. A question here and then there.
All right, thank you. Nick Muad from Bay City, Michigan. So thank you very much for the compelling discussion, but I think in this day and age, a lot of this stuff comes down, in my opinion, to finances. And so we have to justify the extra expense if we want to say go ahead with an independent board, as we say. So my question for the panel is, assuming that we had the money to do this, would that change anybody's opinion?
Well, I guess, the point is, what do the members want to spend? Because the SVS can certainly front some of the money, but that will take away from some other opportunities. Right now, we're spending a lot on branding, some other issues. If we loan $10 million, that's going to cut off some of our reserves. So it's a matter of where are our priorities, and I'm not saying which way is right.
So I'm going to say something controversial. And I have some hesitation, but these are deep inside thoughts that I should probably keep to myself. But I am the rising chair of the Vascular Surgery Board. And there are days where I would rather be a freestanding board. And those are days where I can't get the psychometrician to answer my call. I can't get our publicist to get me some slides on time. I can't, make the situation that I want to fix on time. Are you willing to double your board fees so I can get easier access to our psychometricians? Because that's the call. That's what I see we would get. It'd probably function a little bit better. We'd probably have more access, but these are things that are headaches for me. I don't want to put those headaches on the 4,000 vascular certified, members in the country and double your fees because I'm a little bit annoyed sometimes.
I'd pay $500 for you, man.
Thank you.
I just want to say that when we talk about if we had the money, where do we think the money's coming from? And how much are we spending on branding? I believe it's $1 million?
It's over 3, I think.
Is it $5 million?
It's about $1.5 million this year.
Okay.
It's going up. It's
2 years.
It's a multi-year. It's multiple years that we're doing this, and it's several million, and there are other initiatives. So it's a matter, is there money in reserve? Yes, it is for major projects. So it becomes, is this an important enough project to take away from other projects?
Okay, and I think that's really what the discussion is about. I agree, and I think it is critical that the membership is involved, and I just hope we're doing enough to make sure that as many members as possible are going to answer that poll. I hope it's just not going to be a simple email that comes out asking first, here's a survey, fill it out. I hope we're doing everything we can to market that. That's worth spending money on. because I agree with you, Dr. Calagaro, that if 50% of the members vote, it doesn't nearly mean as much if 90% of the members vote. And so I think we should be and if 90% of the members want to do this, I think you're going to have a real challenge not doing it.
Or if 90% don't. I mean, it goes both
Or
ways.
or don't, yeah.
But-
It makes it easy.
Just so people understand the process, you've all hopefully gotten the survey. If you respond, you're done. If you don't respond, we're going to bug the hell out of you every other day. There's going to be another email coming asking you to respond. We're trying to maximize the response rate. But having said that, people get tired of surveys, but we think it's important.
Dr. Matos, we only have less than a minute.
Can I just
Dr.
real
Matos.
quick riff off of Dr. Sheehan's comment? So there are two people in the room who are directors of the American Board of Surgery who are vascular surgeons, and there's a past chair of the American Board of Surgery in the room who's also a vascular surgeon. So if I would say, Mal, and this was just a little sidebar, if vascular surgery is getting inadequate or inappropriate service from board psychometricians, et cetera, then I think that's something that should be called out. And if it's maybe just, hey, they're busy and PEDS requests and surgical oncology requests and other requests are also sort of managed as they're managed, then that's one thing. But we've talked about vascular representation on the RC. There's also vascular representation on the board of
Dr.
directors.
Matos, a quick question.
Yeah, sorry. I had two questions, but I'll only do one. So there's a lot of young trainees in the room, and there are a lot of young vascular surgeons in their room. And within the last 5 years, there's 1,000 of those. The message you guys are sending is mixed. How do we create a positive spin on this conversation for the young trainees as they go out there having to battle with specialties who want to take over their practice? Because my second question to all of you is, how do you think your practice is going to change in 2026 when they get their board? That's the question that all of you need to answer, because all of you are in different venues, private practice, community-based, hybrid, pure academic. And that's the question that I have to ask my trainees who are going to go out into practice. You have to be aware that somebody's coming for your job.
So here's what
And
you
it's
do,
not
Mark.
another vascular surgeon.
Here's the positive spin. Number one,
Yep.
this is a very
Kelly, I think we
controversial
gotta-
issue, and we're sitting here having a civilized discussion about it, right? I'm not upset with any of the people on this panel who disagree with me, and I don't believe they're upset with me. So I think, number one, we can have this discussion in a civilized manner, and I think that's something to applaud. Number two, if you want to make sure that somebody's not coming for your job, get involved in local hospital administration. Get in local leadership. That's where you stop the stupid stuff from happening. Become the CMO of your hospital. Get on the credentials committee. Get on the quality committee. Put your time in there. That's where you stop the stupid things. The harder part about that, and you maybe, I don't know if that's what you're saying, but the harder part about that is the independent OBLs. And the SVS is working on the vascular verification for OBLs, but that's a different issue. That's a regulatory issue as well. But being board certified independently or in a separate board versus the current board, I don't think it changes anything.
I think we got to conclude the session, but thank you, and those would be some good questions for the audience to consider as we adjourn. And I just want to thank everybody on the panel for an outstanding session. And thank you also for your commitments to vascular surgery. You're all doing amazing things, so thank you so much.